Bagibeli indzaba yemjovo nasikhuluma indzaba yokuthi sisemphini silwa nemkhuhlane i-COVID-19 ngiyona ndzaba lengisho ukuthi isematheni kulamalanga even labo makhelwane eNingizimu Afrika bese vele balungele ukuthi baqale i-rollout yokuthi kumbe baqale bawusebenzise lo mjovo i-AstraZeneca yaka Oxford noko ke bese sekuvela imibiko lesho ukuthi kwangazuthi lo mjovo lona awusebenzi kumbe ngelizinga leligculisako kanti ke nathi ekhaya eSwatini indvuna yetempilo lizinkosi seyivele nayo ivetile iposition lethethwe nguhulumende ngawo lo mjovo njengaloku nayimemetela kumbe evikini leliphele yayishito lokuthi ibatch yeqala emjovo lesitawu thola ngolona waka AstraZeneca namhla ke mbukeli sifuna kuyikhuluma lenzaba noko akusiko kuyikhuluma empeleni kulalela nje nayikhulunywa ngawusho ukuthi etingcwedi tayo ikhulunywa kumbe ku level yaka WHO lapho khona ke eGeneva iWHO ibita nje imihlangano lapho khona ifike iyendela uma briefings nebetindzaba libito lami ngiJohn Moleleke nganzi ke lihlelo iCovid-19 special coverage ulethelwa ngumsakado wayo Eswatini TV njalo ke mbukeli senguvedele ukuthi sifuna kuya lapha emhlanganweni wayo iWorld Health Organization sive ukuthi bona njengaloku sebevile by WHO lokuthi kunalama concerns la khona ngalomjovo engabe bona ithini iposition ye WHO utawusemukela ke DG Director General Tedros sive ukuthi engabe basi backs up njengaloku kunetingcoco kanzi ke kiyo le press conference lena ndawusho ukuthi bakhona nabo so science lababuya event eNingizimu Afrika bodokotela labatayikhulumisa lenzaba kuze mbukeli sithi nasikhuluma nathi sikhulume ngekuthi siyayiconza lenzaba ngoba yinyenti information letfolakalako ikakhulu kati kulamalanga alomkhuhlane weCovid-19 lenye yayitfola ukuthi ayisilo nani liciniso asesihambe ke thina nawe mbukeli singene lapha ku press conference yayo iWHO sive tingcoco ukuthi tichubeka tithini.
Good morning, good afternoon, and good evening. The Oxford AstraZeneca vaccine is one of several that has been shown to be effective in preventing severe disease, hospitalization, and death from COVID-19. The emergence of new variants of the virus has raised questions about the potential impact of those variants on vaccines. Yesterday, South Africa announced that it was putting a temporary hold on the rollout of the Oxford AstraZeneca vaccine after a study showed it was minimally effective at preventing mild to moderate disease caused by a variant first identified in South Africa. This is clearly concerning news. However, there are some important caveats. Given the limited sample size of the trial and the younger, healthier profile of the participants, it's important to determine whether or not the vaccine remains effective in preventing more severe illness. These results are a reminder that we need to do everything we can to reduce circulation of the virus with proven public health measures. Several countries are succeeding in suppressing transmission, including those where new variants are circulating. We all have a role to play in protecting vaccines. Every time you decide to stay at home, to avoid crowds, to wear a mask or to clean your hands, you're denying the virus the opportunity to spread and the opportunity to change in ways that could make vaccines less effective. It also seems increasingly clear that manufacturers will have to adjust to the evolution of the virus, taking into account the latest variants for future shots, including boosters. We know viruses mutate, and we know we have to be ready to adapt vaccines so they remain effective. This is what happens with flu vaccines, which are updated twice a year to match the dominant strains. WHO has an existing mechanism for tracking and evaluating variants of the virus that causes COVID-19. It's vital that countries continue to report these variants to WHO so we can coordinate global efforts to monitor their impact and advise countries accordingly. We are now expanding that mechanism to provide guidance to manufacturers and countries on changes that may be needed for vaccines. These developments highlight why it's so important to scale up manufacturing and roll out vaccines as quickly as possible and as widely as possible to protect people before they're exposed to new variants. We also need to continue designing and conducting new trials, and we need to keep a close eye on the impact vaccines are having on epidemiology, severe disease, and death, so we can use vaccines to maximum effect. WHO Strategic Advisory Group of Experts on Immunization, or SAGE, has met today to review the Oxford AstraZeneca vaccine and to discuss these new developments. Tomorrow, I will meet with the chair of the SAGE to discuss its recommendations. To say more about the new study in South Africa and its implications, I'm pleased to welcome Professor Salim Abdul Karim, the co-chair of South Africa's Ministerial Advisory Committee on COVID-19. Professor Abdul Karim, thank you for joining us today, and you have the floor.
Thank you very much, Dr. Tedros. It's indeed a pleasure and an honor to be here with you. I'll just briefly share with you the reasons behind the South African decision and how we are viewing the situation. So put very simply, we have been monitoring how the different vaccines are stacking up in terms of their laboratory assays, whether they are tested in a pseudovirion assay or in a live virus plaque assay. To date, 5 of the 8 vaccines that we've been monitoring have had these laboratory assays. What they show is that vaccine-induced antibodies have greater difficulty neutralizing the 501Y V2 variant than they have against pre-existing variants. We saw substantial declines in some vaccines and less so in others. So, for example, with Pfizer and the Sinopharm vaccines, we saw minimal reduction in the potency of the antibodies and minimum changes in neutralization activity. However, with other vaccines, such as the AstraZeneca vaccine, we saw very substantial reductions in neutralizing activity. We don't fully understand what those laboratory results mean, so we need clinical data. Fortunately, 3 of the vaccines have been tested in South Africa, where the 501Y V2 variant constitutes about 80 to 90% of the circulating viruses. The first results that we heard were from a vaccine produced by Novavax. And there we heard quite concerningly that the efficacy of the vaccine was 89% in the UK, but only 49% in South Africa. That was the first indication that efficacy levels would be diminished in addressing the 501Y V2 variant. Most recently, we saw this week the release of a study. It's quite a small study with 2,026 participants, largely young individuals. And one of the important things is that the trial used a dosing interval that is quite short compared to the newer, longer intervals that are being proposed by AstraZeneca. So looking at that, what was shown that while the overall efficacy of the AstraZeneca vaccine was 66% in the largest study that include the UK, Brazil, and South Africa, the South African data on its own showed only 22% efficacy. It should be noted it has a very wide confidence interval that includes even 60% protection in that confidence interval. But that study, which looked at only mild and moderate infections, raised concerns. Not because that we were not expecting some diminishing activity, but it was the level to which it was diminished. And so now we are unclear and uncertain about the efficacy of the vaccine in preventing hospitalization and severe disease. We know from the overall trial that the AstraZeneca vaccine is effective against other pre-existing variants. We're just not confident about its efficacy against the 501YV2 variant. And so we've proposed an alternative approach, a new approach to the way in which to roll out the vaccine. And one proposal that's currently being considered is to roll it out initially just in a stepped manner, where the first step includes about 100,000 individuals that are vaccinated, in which we monitor the hospitalization rates. If they are below the threshold that we are looking for, then we're confident that the vaccine is effective, again, in preventing hospitalization, and then we can roll it out. Alternatively, if it's above that threshold, then we'll need to look at alternatives. So put very simply, we don't want to end up with a situation where we've vaccinated 1 million people or 2 million people with a vaccine that may not be effective in preventing hospitalization and severe disease. We think that in order to do so, we have a more prudent way in which we can do that, which is to make an assessment and then roll it out on a grander scheme. So all that has been suggested at this point is to delay the rollout of the AstraZeneca vaccine until we have the processes in place to undertake this kind of stepwise implementation approach. On that note, Dr. Tedros, thank you very much.
Thank you. Thank you so much, Professor Abdul Karim. And we appreciate everything you're doing in South Africa and globally in the fight against COVID-19, as you have done for so many years in the fight against HIV. You have our respect and appreciation, Professor. In the next few days, WHO expects to make a decision on the emergency use listing of the Oxford AstraZeneca vaccine for the 2 sites in India and the Republic of Korea, which will produce it for COVAX. We're committed to using all available data to make these assessments. In the meantime, COVAX continues to prepare for its first quarter distribution and to add to its vaccine portfolio. To discuss the implications of this new developments in South Africa for COVAX, I'm pleased to be joined today by Dr. Seth Berkley, the Chief Executive Officer of Gavi. Seth, welcome once again, and you have the floor.
Thank you, Dr. Tedros, and also thank you, Professor Karim. It's good to have you here with us. You don't have to be an epidemiologist, as Dr. Tedros said, to know that these viruses evolve and mutate over time. I think the events of the past weeks, the emergence of these new variants, and this has been a sequential conversation. We've heard about the B117, known as the UK one. We just heard about the South African one. There's also one in Brazil that is known as P1. What this serves to highlight that our scientific response needs to adapt if we're going to successfully beat this pandemic. It isn't simple. It isn't going to be one strain globally. So from the perspective of COVAX, the vaccine pillar of the ACT Accelerator, there are a number of lessons that are important from these events. The first is that manufacturers must be prepared to adjust the adjust to COVID-19 viral evolution, including potentially providing future booster shots and/or adapted vaccines if found to be scientifically necessary. We don't know that now, but that is something that obviously needs to be carefully followed. It's also clear that trials have to be designed and maintained to allow efficacy to be assessed over time and to be of sufficient scale and diversity to enable clear interpretations of the results. We know that we need much better global genomic surveillance, and that has to be backed by rapid sharing of data to allow for the global coordination of response. And then lastly, and I know this has been said, but it needs to be emphasized, priority needs to be given to vaccinating high-risk groups everywhere to ensure maximum global protection against old and new strains and to minimize, as best as the vaccine can, the risk of transmission. Because we know the more that the virus is allowed to spread, the more it is allowed to be transmitted, the more opportunity it has to adapt and mutate. mandate. All of this underlines the need for a global multilateral solution based upon the principles of equitable access. It also underlines the need for a diverse portfolio of vaccine candidates suitable for all context, setting, and events. In terms of COVAX, we have signed advance purchase agreements with AstraZeneca and the Serum Institute of India, and we've published plans to distribute nearly 350 million doses in the first half of the year, hopefully starting later this month, should the emergency use listing be forthcoming that Dr. Tedros just talked about. And of course, this is the first of many vaccines. We'll also be looking at the SAGE guidance that you heard about in terms of their views on the best use of this vaccine in different groups and in different areas. We're continuing to work through our partner, CEPI, and Richard Hatchett, CEPI's CEO, is on this call to optimize and extend the value of these existing vaccines. We're looking to continue to procure new candidates for our portfolio for use later in the year, including ones that would be adapted for the new variants if scientifically indicated. As we have done up until now, we'll continue to keep you updated on all these developments as and when they occur. So thanks for giving me a chance to speak, and back over to you, Dr. Tedros.
Thank you. Thank you so much, Seth. And we look forward to our continued partnership to roll out vaccines. I would also like to welcome Dr. Richard Hatchett, the CEO of CEPI, which is a key partner in COVAX. And Richard is also available to answer questions from journalists. Thank you once again to all our guests, and apologies for the delay. And Fadila, back to you.
Thank you, Dr. Tedros, and to our guests. I will now open the floor to questions from members of the media. I remind you that you need to raise your hand using the raise your hand icon in order to get in the queue to be able to ask your question. I would like now to start this session by inviting Sophie Mokoena, SABC, South Africa, to ask the first question. Sophie, you have the floor.
Hello. Hello.
Sophie?
Yes. My name is Sophie Mokoena from SABC in South Africa. I just want to find out from the panel. We know that during the Spanish flu in 1918, the pandemic was deadly to senior citizens and later to young generations because of the very same problem of perhaps the change of the virus itself. Did the scientists, particularly people with a better know-how, not anticipate that this virus will mutate and we might have problems, so that the developers of the vaccine and manufacturers must take that into consideration? Because what guaranteed we have that during the third wave, it will not have another form, and previous vaccines won't be effective.
Thank you, Sophie. Your question is well understood. Dr. Mike Ryan?
I can start, Maria, continue. I think the issue is in 1918 we didn't even know this was an actual virus causing influenza at that time. So therefore, there were three distinct peaks in terms of age groups in the 1918-1919 pandemic. We had the classic peaks in the younger, very young, and classic peaks in the very old. But what we had very unusually was a huge peak amongst young individuals, particularly amongst young men. Some of that may have been due to the virus, some of that may have been due to the mixing of people and the bringing together of young men in camps. But it was a fulminant disease disease that killed very, very quickly and had that very distinct shape. The first, second and third waves, the second wave was larger than the first wave, and again, we don't know that, but the virus may have becoming more fit to the transmission in the human population, and a first wave may have been better adapted in a second wave, and that's what happens. Flu viruses adapt and they evolve over time, and you see that every year as we change the vaccine strain. Every year, the strains that are in the vaccine. We look at the predominant strains, the most successful strains that are circulating, and the ones that are causing clinical illness. We track the epidemiology of the viruses, we track the type of the viruses, we track the proteins on the surface of the cells, we track their genetic sequences, and every year we're able to give clear instructions to manufacturers on how to adapt influenza vaccines. I think with the same kind of approach here, with the same sort of diligence, both in epidemiology, in genetic sequencing, and in doing the observational and other studies we're going to need to do to understand vaccine efficacy, I believe we can track this virus. We have the tools that they did not have in 1918 or 19, and we have the means to adapt and be flexible and react to what we see. So I'm confident that if the scientific, public health and governmental worlds come together, we can have a strategy that will adequately adapt to the emergence of variants.
Yes, and if I could outline a little bit about that strategy, because it is developing over time and it is getting stronger over time. So as this is the first coronavirus pandemic the world has ever seen, we have established surveillance systems around the world, as you know, looking for where the virus is by tracking individuals who are infected with this virus. But along with that, scientists and virologists have been tracking the virus itself and any changes in the genome of the virus itself, looking at mutations and the virus evolution, which is a natural process for all viruses and all pathogens. And what we've been doing through our virus evolution network and our laboratory network, and through the improvements of genomic sequencing around the world, countries have been sequencing viruses in their countries, and they have been sharing those viruses on publicly available platforms like GISAID and others, so that the changes in the virus can be evaluated, they can be studied, and that we can determine what they mean. Because even if viruses change all the time, what is really critical is to have an assessment framework in place so that we can determine if any of these changes reflect or result in a change in transmissibility, reflect any changes in disease presentation and severity, and importantly, if any of these changes have any impact on available and future diagnostics, therapeutics, and vaccines. And recognizing that this was important for us to be monitoring, we formulated our virus evolution working group in June to have an assessment framework to determine what studies were necessary in the lab where we could look at specific mutations, but also variants of interest, because we need to determine which ones of those are important to become variants of concern. And now what we're looking to is building on existing systems like we have for influenza. How do we take the knowledge of the way that these vaccines behave in terms of the neutralizing response and in terms of the impact of these vaccines, but not only vaccines, also therapeutics and diagnostics, to say, this is important, and therefore there may be a change necessary for the vaccines. So that is a process and a mechanism that is being enhanced, as the Director General said in his speech today. But again, we're not starting from scratch. This is what scientists do. It requires a robust framework to detect these mutations and variants. It requires strong collaboration across scientists and labs around the world so that studies are done to actually properly assess the potential impacts of these viruses, and also to inform vaccine composition. So there's a lot that's in process here. It will become stronger as the months go on, and it really requires the help and the persistence of everything from epidemiologic surveillance all the way through good collaborations with manufacturers.
Thank you. I would like now to invite Mr. Richard Hatchett, CEO CEPI, to add some elements. You have the floor, sir.
Thank you. And Sophie, thank you for the question. Just to say that as Maria and Mike have indicated, we certainly have anticipated that the virus could mutate. In fact, scientists working in laboratories anticipated some of the mutations and this is one of the values actually of doing the science. It allows us to essentially to look into the future, to look at possibilities that may occur, and to help us look out for mutations that would be of concern and interest, as Maria just outlined. Certainly the emergence of the new strains in South Africa and Brazil and the UK has given cause for concern. We had taken a risk management approach, not only through COVAX, but globally in terms of the approach to vaccine development, and had undertaken the development of vaccines on a wide variety of platforms. The mRNA vaccines, of course, the viral vector vaccines like the AstraZeneca vaccine that we've been discussing, recombinant protein vaccines, and inactivated vaccines. Having that diversity of vaccine candidates actually provides us with a large number of tools which we need to explore now to see which work best against the variants that we have. We can also look at potentially at combinations of the vaccines that we have. And of course, we must accelerate the development of new strain-specific vaccines. And a large number of companies have already begun to undertake that work. And if the evolution of our understanding of these viral strains, suggests that we do need to progress those vaccines into clinical trials and then into use, we will do that as quickly as we possibly can.
Thank you, sir. I would like now to invite John Cohen from Science to ask the next question. John, you have the floor.
Thank you so much for taking my question. I well recognize that this study in South Africa didn't have enough people or old enough people or people with comorbidities to answer the severity and hospitalization and death question. But we have a lot of data from other studies that suggest that vaccines that don't work particularly well against mild and moderate disease could possibly still keep people out of hospitals and prevent deaths. I'm curious, and I also recognize that WHO doesn't tell countries what to do, but I'm curious what outside people, experts, think about South Africa's decision to suspend the use in healthcare workers right now in order to wait to form the trial that Slim described. So I'm curious if you could address that. What do you think of that decision to suspend the use right now, given the potential that it could prevent people from being hospitalized and dying?
Thank you, John. Dr. O'Brien will take this question.
Thanks for that question. I think underlying the question is really a recognition of what a dynamic situation it is right now. The evidence has come out very recently within the past 24, 48 hours. As the Director General indicated, the Strategic Advisory Group of Experts on Immunization at WHO met today, along with the investigators from the trials that are being conducted in the UK and Brazil, along with AstraZeneca and along with the investigators from the South Africa trials as well. And so everybody's looking at the data right now, and there are a range of ways that this can be approached. But I think what was most clear that came out from the SAGE meeting is that in looking at the evidence on the AstraZeneca vaccine across a number of trials, it is very clear that it has efficacy against severe disease, hospitalizations, and deaths. Among the variants and different variants, there is some reduction in, some indications of reduction in the efficacy, some more, some less, depending on which variant, which population, and also of the neutralizing antibody responses. But we also have evidence that there is the likelihood that the retention of meaningful impact against severe disease is a very plausible scenario for the product against the B.1.351 variant. And so as South Africa deliberates on how they will handle the situation, recognizing that there are a range of products that they're looking at, and how to get more data on exactly what would sort of inform a greater and broader policy, These are discussions, as we've heard, that continue to be underway about exactly how they will use the vaccine that they have in hand to its maximum benefit, and assure that there is evidence that can inform not only a broader policy in South Africa, but helps to inform policies around the world. So we'll see the final wording that comes out from SAGE on the use of the vaccine, but there was a very positive view about proceeding with the use of the vaccine, including in settings where variants are circulating, with a big emphasis on collecting information that would really help as in the weeks to come and in the months to come to inform an optimization of those uses in different countries, in different settings around the world.
Thank you, Dr. O'Brien. I would like now to invite Christoph Vogt from IFP to ask the next question. Christoph, can you hear me?
Yes, I can hear you. Thank you for taking my question. I was just wondering about everything we heard now about the AstraZeneca vaccine, and I can see how complicated it is, but how much does it affect the rollout, the number of vaccines that you can roll out, and when for the COVAX facility? It is the bulk of what you plan to use for vaccination in the next 6 months. So I was just wondering if you can give us an answer also after what Dr. O'Brien just said, that maybe we should just roll out and use it to kind of prevent more severe cases. Thank you.
Thank you, Christoph. Dr. Seth Berkley will take this question.
So thank you for the question. And before I answer that question, let me just add one point to Kate's excellent question, and that is we learn more about these vaccines as we work with them. And one important point about the AstraZeneca vaccine is it was studied originally with a dose interval between two doses of a month. As that vaccine has now gone through trials, and observational studies have shown that, in fact, a longer dose interval increases the immune response and also increases the efficacy of the vaccine. So these types of learnings will occur with new vaccines, and that also means that, you know, in a study like the South African study, it was not optimized for what we know today is the you know, the way to get the most immune response out of it, et cetera. And this is part of the debates and discussions that need to go on right now. But going back to the question, the AstraZeneca was really the first vaccine. Of course, we also have doses, a small amount of doses of the Pfizer vaccine now as well as early vaccines in the portfolio. But the idea was to try to get a very large portfolio of products, and we have done that. So we will be seeing other vaccines enter the portfolio and be available for participants of COVAX in the second quarter. And so it is true that initially it'll be mostly AstraZeneca and Pfizer that are moving forward, but then there'll be more vaccines. And of course, as Dr. Hatchett said, one of the things we'll be looking at is whether any or all of these vaccines need to be adapted and adjusted either in the way they're being used or even in the actual makeup of the vaccine. So this is an evolving science, as you heard from Kate, and we will continue to work as COVAX to ask the question, what is the best way to move forward? But at the moment, at least, and we'll wait for the SAGE guidance, it looks like the AstraZeneca vaccine is an efficacious vaccine. It's been reviewed by a number of stringent regulatory authorities and gotten approval, and had studies in many countries, including efficacy against severe disease, as you've heard, including efficacy against some of the changing variants, and therefore we suspect that we will continue to roll that out and will continue to follow the effects of that vaccine over time. Over.
Thank you, Dr. Berkley. I would like to invite Professor Salim Abdul Karim to also provide some elements to this question. Professor, you have the floor.
Thank you very much. Just to add a quick comment, that even in the South African setting, we were scheduled to roll out the AstraZeneca vaccine in just over a week from now. We anticipate that the initial start date of vaccinations will be largely unaffected or at most affected by a few days. But instead of rolling out AstraZeneca vaccine, we'll be rolling out the Johnson & Johnson vaccine. And that'll give us a bit of time and leeway to ensure that we're collecting the necessary data as we roll out the AstraZeneca in a stepwise process. So it doesn't really materially affect our start date. It may affect the rate at which we escalate if we start running short of doses. But as it stands, it should not affect much else. Thank you.
Thank you, Professor. I would like now to invite a Brazilian journalist, Sara Teofilo, from Corriere Brasiliense, to ask the next question. Sara, you have the floor.
Hi, thank you for taking my question. Still on the subject of the variant in South Africa and the suspension of the use of the Oxford vaccine, in Brazil we also have a variant identified in Amazonas, as was said here today, and we know it is a different variant, but does the organization have any orientation to Brazil? Should the government suspend the use of the AstraZeneca vaccines and use the other vaccines until we know that this variant does not interfere with the effectiveness of the vaccine?
Thank you. Dr. Swaminathan, you have the floor.
Thank you for that question. And again, just to repeat what others have said, we are seeing, we're learning a lot. There are uncertainties still. We don't have answers to all questions. The SAGE, the Strategic Advisory Group of Experts on Immunization, is reviewing all the evidence that's available on each of the vaccines from all the different studies, starting from very early clinical, all the way to the phase 3 trials, and also taking into account what we know about the different variants and the experiments that have been done, both in the laboratory, looking at neutralization assays, and if there's any clinical evidence, taking that into account, and will make recommendations based on the available evidence. And of course, these can be updated and revised as more data becomes available. So all of our guidelines are meant to be, updated. They're living guidelines, and we will do that, but again, based on the best available evidence. Countries, of course, will make their own decisions based on additional information that they may have, and we can help them and work with them to make those decisions. One thing I would like to say is that there is an urgent need to collect more information and data. So even as countries are rolling out vaccines, whatever the vaccines may be, it's really important that we put in place mechanisms to either do clinical trials where you can randomize, for example, the question about the optimal timing between the 2 doses, the question of, its efficacy in different age groups, the question of is it better to use one vaccine followed by a different vaccine as a booster dose? All of these questions need to be answered. And we would like to promote that kind of, good research, whether it's trials or whether it's observational studies, cohort, that are monitored for both effectiveness and safety, and then have a global database where we keep learning so that we use these vaccines more effectively, even as Richard Hatchett was saying from CEPI, we are investing in the development of more vaccines. Those trials need to be done as well. So I think the next few months are going to be important for us as we roll out.
Ukeli ngiyethemba ke sothi vele njalo kusesiphelelwe isikhathi kiwo lo mhlangano we-WHO ukuthi kuyakhulunywa lapha indzaba lenkulu ngicabanga ukuthi ngiyo le COVID-19 viral evolution lokuthi leli gciwane liyagucugucuka lisagucugucuka ke iyavela nemijovo kodwa lokunye lokuvelayo ukuthi nabo labakhala imijovo kumele lokuthi balungele lokuthi nasekubonakala ukuthi leli gciwane seliphinze ligucukile baphindze bakhona ukuthi umjovo wabo kumbe babukele ukuthi bangawubooster njani kwendela ukuthi ube ngilo lonemandla kanti ke mbukeli njengaloku kuvela ukuthi na7 learnings in Africa base bambile lokuthi bangamsebenzisa lo AstraZeneca kodwa ke bathi batawusebenzisa Johnson & Johnson bamsebenzisa nje Johnson & Johnson kusafuna kubuka lama trials ukuthi engabe AstraZeneca utawugcine alunga into ukuthi angasebenza lokusho ukuthi nathi la eveni la Eswatini sikathile lokuthi WHO itathi naseyihlangene nebaka search njengaloku bayasho lokuthi basabuka lokuthi engabe lo mjovo usebenza kanjani bataseke bayasadisa sekuyabonakala lokuthi nathi silive kumbe siyachubeka nawo lo mjovo noma kumbe sisebenzisa letinye inhlobo temijovo njengaloku yasho indvuna etiko letempilo lizinkosi ukuthi nathi silive lo mjovo botawuchamuka ngidawusho ngetigaba letahlukahlukene sigaba sekucala bekunguye AstraZeneca waka Oxford kodwa ke njengaloku kwamile siyathi ukuthi naye Pfizer usendleleni siyathi ke ukuthi kumbe sitawugcina sifika nakubo Johnson & Johnson ngete ukuthi sitawugcina sitfola yini ukuthi singagcina sitfola neSputnik sase Russia lena ngolomunye umjovo lebathi ukhona emarket embukeli bengikuthethe nje ngekuthi ngikufake lapha kule press conference utotivela so that noma ngabe sesiyakhuluma mbukeli ukuthi indzaba ya AstraZeneca imenjani sikhulume ngekwadi ukuthi sebakhulumile bodokotela sebakhulumile ama scientists nathi stats nasikhuluma sikhulume ngekuyadi kuthi abaselangeni la kusasa ngesikhathi lesifana nako usale kahle.